As always, if you're not presenting, turn off your video and mute your microphone so that we don't have background noise. And for the first presentation, it's going to be Professor Donnacha O'Brien's team presenting. Professor O'Brien is our clinical director at the National Neurosurgical Centre in Beaumont, and the Una Brennan and James Maxwell are going to be presenting together a case of a major head and cervical spine injury combined. So, and if you do, people who have questions, put them in the chat and then I'll read them out at the end. So let's kick off, Una.
Thank you. So good evening, everyone, and welcome to the monthly National Neurotrauma webinar. So our presentation is titled A Major Head and Cervical Spine Injury Combined. So we're going to discuss a case report. We're going to review the evidence of craniectomies versus craniotomy for extradural hemorrhages in the polytrauma patient. So brief recap on extradural hemorrhage. It's collection of blood within the potential space between the outer layer of the dura mater and inner layer of the skull. Accounts for somewhere between 20 to 50% of traumatic intracranial hematomas. The most common cause we see is secondary to falls, assault, or sports injury, and the highest incidence being in the very active age group of 20 to 30 years of age. 75% are associated skull fractures, and the clinical picture often is there's a loss of consciousness, regaining of consciousness, and loss of consciousness again, or the classic lucid interval. So a little bit about the pathophysiology. So it results from interruption of dural vessels, so the middle meningeal artery. You can get brain herniation up to 24 hours post the trauma, depending on the volume of the bleed. So this leads to decreased cerebral blood flow, cerebral edema. Then you get ischemia, an infarction, and raised ICP has been shown to be the main contributor to the infarction. If the bleed continues, you get further elevation of the ICP. Clinically, the patient may develop an ipsilateral pupil dilation, secondary to uncal herniation and cranial nerve decompression. And then you may see the triad of elevated blood pressure, slowed heart rate, and regular breathing, or Cushing's reflex. So a brief slide differentiating craniectomy versus craniotomy. Very similar procedures. However, in a craniectomy, there is usually a second operation, so the bone is not immediately replaced. This can be an emergency situation, such as a traumatic brain injury, and you need to relieve ICB or subdurals. Craniotomy, on the other hand, is where it's all done in one operation. The bone is replaced with and secured with plates and screws, often done as part of a planned procedure, such as a brain tumor, biopsy, or vascular malformation surgery. So, on to our case study. We met a 37-year-old gentleman. He sustained multiple serious injuries. He fell 3 meters from a forklift. He was working at home on the farm at the time, had right-sided head strike on concrete ground. So just for a bit of context, the picture in the top right of the screen gives you an idea of the 3 meters, the machine he was on, and the concrete ground below that he hit head first. So he sustained a number of injuries. So on the slide, you can see he had an extradural hemorrhage, a subdural hemorrhage, a temporal bone fracture, he had C7 vertebral fracture, dislocation right shoulder, left partial torn Achilles tendon, and right-sided distal radial fracture. So he had many injuries after the fall. So he was found on the farm and an ambulance was called immediately, and he was brought to Galway Emergency Department. On arrival, his GCS 14 out of 15 and his eyes were opening voice. Just for the clinical picture, he had a forehead laceration, he was bleeding from his ears, he was moving all 4 limbs on presentation. He was vitally stable initially, and trauma imaging was performed. However, he became unstable, his GCS dropped, he became confused and drowsy, so he was intubated and ventilated. Full spinal precautions were applied. Neurosurgery in Beaumont were contacted for advice on management of this patient. So they advised to give him Metal and get an emergency transfer in ambulance to Beaumont Hospital and to come straight away. En route to Beaumont, he developed a right-sided unreactive pupil, so further adding to the urgency of this case and the need to get him here as soon as possible. Just to note, the patient had no significant medical history. He wasn't on any blood thinners or any regular medication, and there was nothing significant in history. So in terms of investigations, his CT brain from Galway showed a 5mm extradural hemorrhage with a 4mm midline shift. However, the CT brain, which is the one that's on the screen now that he had done urgently when he arrived to Beaumont, showed an extradural hemorrhage measuring 8.4 AP by 2.7 by 8, and this approximates to about 90 centimeters cubed for volume. Also, there was a non-displaced fracture of the temporal bone and right-sided hemotympanum. Anteriorly, there was a 7mm subdural hematoma overlying the right frontal and parietal lobes, which is just a bit hard to appreciate in this slice. And the hematoma at this stage in this scan was associated with 11mm right to left midline shift, right uncle herniation, 5mm cerebellar tonsillar herniation into the foramen magnum. So ECT brain findings indicated that neurosurgery intervention was needed immediately. So I have a video here that I'll play on the slide for you. So this is the pre-op cervical spine, the sagittal section. So it shows a C7 burst fracture with impingement on the thecal sac. So I'll just play that now for you. Right here we have the pre-op cervical spine CT scan as well, and the axial view. Just play that now. So you see the burst fracture with retropulsion compressing the spinal cord in this video. Now we have a video, and this shows the CT brain that was done pre-op. So you can see on the right-hand side, the extradural hemorrhage and the subdural anteriorly. So when the patient came to Beaumont, I've just run through neurosurgical intervention received. So he underwent immediate evacuation of the extradural hemorrhage. In theatre, he had a decompressive craniectomy, ICP monitor inserted, the subdural was evacuated, and bone flap was placed in the abdomen. So the patient needed a C7 correctomy and anterior cervical fusion as well. However, he became unstable intra-op when he was getting his extradural hemorrhage and decompressive craniectomy surgery. So it was decided that the patient was not stable enough for this at the time. So the next day, a C7 corpectomy was performed with anterior cervical fusion, and he also had a right distal radial open reduction internal fixation performed by the orthopedics team. The anterior cervical fusion was performed by Mr. David O'Brien, neurosurgeon. You can see there, this was the CT brain, day 1 post-op. So here is an X-ray of after the C7 corpectomy, and it shows the anterior cervical fusion. And as we said, it was done day 1 after the decompressive craniectomy due to the patient being unstable. So post-op, the patient was monitored in ICU. He was monitored closely. 5 days later, he's extubated. He had respiratory complications, so he was treated with flucloxacillin for this, and he responded very well. Eventually, he was transferred to the ward with the goals of rehabilitation and cranioplasty planning. So the CT brain on the left is the CT brain that was done 12 days post-op. So here we have another video. This shows the CT brain post-craniectomy. So you can appreciate on the right-hand side, the bone has been removed and the swelling of the brain. And this one, approximately 1 month later, just under a month, the patient underwent cranioplasty and the bone was replaced. So this is another video, and you can see how the patient was post-op. So here you can see the bone has been replaced. So in terms of patient recovery, how did he do? He made an outstanding recovery. So at the moment, his GCS is 15 out of 15. He's independent for all ADLs. He's nearly back to baseline mobility, bar a boot and 2 crutches for 6 weeks. His fractures have been managed by orthopedics. He had his cranioplasty surgery, he's doing very well post-op. His current issues, subjectively, the most frustrating thing for him is his left partial Achilles tear. Ongoing management is neurosurgical and orthopedics outpatient appointments. He's undergoing physiotherapy, occupational therapy in Galway. So this case really highlights the effectiveness of the MDT intervention this patient got in the acute stage with neurosurgery and ICU, and the subacute stage with OT, physio, and orthopedics team as well. So, decompressive craniectomies is not always performed. This case was very interesting. The early scanning intervention by the neurosurgery team ensured that the patient got the best outcome possible and is nearly back to baseline. However, one thing that this case does highlight, and when we went to research it, was the lack of evidence surrounding decompressive craniectomies versus craniotomies in the extradural hemorrhage population cohort. So I'm going to hand you over to Dr. James Maxwell, who's going to take you through the evidence now.
Thanks, Una, for presenting this interesting case. So my name is James. I'm just going to talk you through the evidence surrounding our case presentation. So craniectomy versus craniotomy, what does the evidence say? There's a paucity of evidence regarding the outcomes of decompressive craniectomy, or DC, versus craniotomy in the setting of ED within the current literature. And controversy exists regarding the optimal surgical options. To date, there is no clinical trial involving level 1 evidence consisting of an RCT or systematic review that has investigated the validity of decompressive craniotomy in EDH patients with polytrauma as seen in this case report. Decompressive craniotomy are effective at reducing ICP, refractive to conservative management, but their effect on outcome measures remain unclear. So the PICO framework was established by Richardson in the middle of the 1990s and allows us to answer a health-related question. And the important question here is, why is there so little evidence for decompressive craniectomy versus craniotomy for treatment of EDH within the polytrauma population cohort? If we just focus our attention to the patient or key aspect of the framework or the problem, we can begin to appreciate that this is the challenge for establishing evidence. I'm just going to talk you through why in the next few slides. So this is an interesting paper by Corey et al. In 2020, so it's 2 years old, and investigates the decompressive craniectomy for traumatic acute extradural hematoma. The interesting aspect of this paper is it gives indicators to perform a decompressive craniectomy. The first indicator is the clinical aspects, such as GCS less than 5, pupillary assembly for greater than 2 hours, bilateral mydriasis, and shock for greater than 30 minutes. The second aspect is radiological, and this is a volume of EDH greater than 100 mils calculated by width, length, breadth divided by 2. Midline shift greater than 1.5 centimeters or 15 millimeters, and territorial infarction such as MDA. The last aspect to perform a decompressive craniectomy is intraoperative. So a significantly larger volume of EDH as compared to preoperative CT scanning. Bulging brain tends dura at the time of close of surgery. So what does this tell us? These patients are sick, hence the lack of evidence. These patients have polytrauma. They have multiple injuries. They're complex management. So they make them not the ideal subject candidate in a clinical trial setting, particularly randomized controlled trial, due to their high rate dropout bias, which will then therefore skew the statistical analysis. Conservative management is often left to clinical judgment. The Brain Trauma Foundation guidelines for the management of severe head injury recommends a patient who exhibits an EDH that measures less than 30 mils, less than 15 millimeter thick, less than 5 millimeters midline shift, no focal neurological deficit, and who have a greater GCS greater than 8 can be treated non-operatively. So the Brain Trauma Foundation guidelines on the management of severe traumatic brain injury is one of the most robust guidelines at the moment. The 4th edition, published in 2016, state that the most debates around the role of decompressive craniectomy in the management of severe TBI and EDH results from the paucity of data coming from RCTs assessing this intervention. So at the moment, where we are regarding evidence-based practice, there's a moderate amount of level 1 evidence consisting of 3 RCT studies investigating decompressive craniectomy for traumatic brain injury, but what about EDH? At the moment, there's no RCT or level 1 evidence. However, there is a good cohort study by Hahn 2008 that compared decompressive craniectomy versus craniotomy for hemorrhagic cerebral contusion. If you look at this cohort study and just focus our attention to the study design, the numbers in terms of the study population was 54. The treatment group was the craniectomy group, and that was 38, and the control group was the craniotomy. The outcome measure is assessed with mortality rate, and the GOOSE, which is the Glasgow Outcome Score Extended, which is used to assess disability and recovery post-TBI. The results of the study show that craniotomy group reported lower, but not statistically significant mortality rates, and conflicting findings about patient function and complications. Now, it's important when we're synthesizing and appraising evidence is to look out for confounders. And just when I was reviewing the paper, it was quite evident that the craniectomy group were sicker, they had lower GCSs, they had high rates of polytrauma, and hence why they had higher rates of mortality. So this paper by Villasinis in last year in 2021 is a retrospective analysis consisting of 60 patients who underwent decompressive craniectomy versus craniotomy. Demonstrated that DC following EDH evacuation demonstrated inferior outcomes in comparison to craniotomy group. However, the craniectomy patients tend to have more severe injuries, such as subdural hematomas, early brain herniation, both of which are seen in this patient in our case report. The mortality was more evident in the craniectomy group, 44% versus 13% in the craniotomy group. It's important to critically appraise the evidence, although the higher mortality rates in the decompressive craniectomy group, these were more severe injuries. So this is a common theme within the research at the moment. The patients undergoing, when you put patients into decompressive craniectomy group in that arm of the trial, they tend to be sicker patients, lower GCS, higher rates of polytrauma. The lack of level 1 evidence is the main furnishing factor for the lack of neurosurgical guidelines for the management EDH amongst the polytrauma patient cohort, causing a wide diversity in practice between hospitals and countries. The protocol RCT titled Predict ADH, or titled Prospective Randomized Evacuation of Decompressive Ipsilateral Craniectomy for Traumatic Acute Epidural Hematoma, aims to compare outcomes and cost effectiveness of decompressive craniectomy versus craniotomy in the treatment of TBI patients with cerebral herniation undergoing acute EDH evacuation, very similar to what we saw in this patient case report. So it's quite an extensive proposed RCT, involves 51 neurosurgical centers. It's 121 patients and aims to evaluate the benefits of DC on traumatic EDH with brain herniation. It's quite a well-thought study protocol, aims to have 120 patients. That's to allow for 20-30% of dropout with one skew to data analysis. And potentially this RCT will provide level 1 evidence, which we need. So in summary, the review of evidence, there's no systematic reviews. The only RCT is the proposed Predict ADH, which hopefully will be coming soon. There's 2 to 3 cohorts or observation studies, such as the Hong 2008 study. And there's a handful of case reports and anecdotal evidence. So in conclusion, this case report highlights the management of a complex polytrauma patient with EDH and cervical spine injury. Practices vary amongst establishment countries, and more evidence is needed to produce standardized international guidelines regarding surgical treatment options from level 1 evidence coming from RCTs. In summary, more RCTs and cohort studies are needed to compare craniectomies versus craniotomies in the EDH patient cohort. I thank you for listening, and we're happy to take any questions. Here's our list of references, and we're happy to take any questions. Thank you very much, guys.
Thanks, James. Thanks, Una.
That's great, Una and James. Fantastic presentation. Nice case and a nice review of the literature. We have a couple of things that have been posted on the chat, and I'll just go through them. And Donica, you may want to comment on some of them yourself. In terms of the instability that happened intraoperatively with that case, was that, do you think, due to the other injuries or the intracranial?
No, it was due to the fact that he just had high noradrenaline requirements to keep his blood pressure up. I think it was a cerebral effect. I mean, as James and Una wonderfully pointed out in their presentation, he had an extradural hematoma, he had a subdural hematoma, he had brain swelling. So we made a decision to do a craniectomy on the basis of his brain swelling and the size of the extradural hematoma. So his instability reflected cerebral instability, and he needed a period in intensive care in order to calm that down and gain kind of quiescence before we could go again. So it wasn't a hypovolemic situation, it was an overall neurogenic issue.
Yeah, and I suppose even if that wasn't the case, I think the C7 corpectomy would be done kind of semi-electively the following day or so.
Yeah. We're lucky in Beaumont, as you know, we have a very skilled spinal surgery service involving Dave O'Brien, Professor Baldrick, Catherine Moore, and Ben Hussein. And so he came in on a Saturday morning. We operated about mid-morning on a Saturday, and we stabilized him in ICU, in Neuro ICU that day. And David very kindly came in the next morning and did a complete C7 corpectomy and put a titanium cage into position and fused it from the front. Yeah, so at that stage, he had 18, 19 hours of ICU. He was stabilized, and then that could take place then.
Yeah, I think it very nicely shows the interaction between, I suppose, cranial neurosurgery, spinal neurosurgery, orthopedics, and then obviously the rehab afterwards. And I
must say that he was, Una in her wonderful presentation there kind of mentioned the fixed dilated pupil, and she very, very academically pointed out, what that means in terms of oculomotor dysfunction and dilatation of the pupil. But, that's a very nice way of saying, this is impending brain death, like a fixed dilated pupil. What that means is that there's pressure on the brainstem and the patient's at risk of secondary brainstem hemorrhage. That brain death is not too far away. So there's an ultra emergency aspect to it. So, he was blue light straight into the operating theater and was whipped straight to theater and had a craniectomy immediately. So a fixed dilated pupil is a very nice term, but what it means is pressure on the brainstem, and one can die from brain death like within an hour,
Yeah, and I suppose it also kind of nicely demonstrates that often in the multi-injured trauma patients, it's the head injury that is often the cause of death, or their most significant injury that needs the quickest. And all the data shows that as well, that the injury that needs the quickest response is often the head injury.
He was transferred by, I think, Garda escort from Galway, and he was in theatre immediately, and had a craniotomy straight away. And we decided to do a craniectomy. I know James, in his wonderful review of the literature there, pointed out the various academic aspects to things, but my feeling over the last 30 years with regard to extradurals is that a large extradural will obviously compress the brain, but there's a big rebound reperfusion injury on taking the clot out, and in terms of free radical generation and that. And I think oftentimes a secondary insult happens after taking the clot out, and I think in the context of a large extradural hematoma, one has to bear this in mind, and that and Professor David Boucher Hayes in Beaumont for years did work on reperfusion injuries, but I think the craniectomy in that setting gives another layer of protection to the brain and that.
Yeah, that was quite an interesting aspect of it, because we don't often think about doing a craniectomy for extradural hematomas. Generally, it's a craniotomy.
So what's wanted us to do this is that, as Una said, is that the patient had a subdural hematoma as well, and we removed the subdural hematoma, opened the duro, and then we obviously found that the brain was quite swollen. So we kind of said, look, the patient had a multi-compartmental brain injury, extradural, subdural, brain cerebral edema, and his brain was going to continue to swell, especially after taking the hematoma out, the extradural hematoma out. So he needed more than just put the bone back in. He needed more than just a craniotomy procedure.
Yeah, and the traditional teaching has always been if you have a subdural, I suppose, that often indicates a higher impact injury.
Indeed.
There was I think they've completely recruited, the rescue subdural hematoma. The Cranebridge crowd have done another trial on craniotomy versus craniectomy for acute subdural hematomas, but I don't think the results are at. Professor Michael O'Sullivan, I think, wants to. You have your hand up, Michael.
Yeah, I'm Wilson. Can you hear me?
Yes, we can.
Just a nuance. What I sometimes do is I do a craniotomy, put on the retaining plates, but don't screw them back into the skull. So let them lie. So if the brain swells, I can actually elevate the bone flap, and then when the brain swelling settles down, the bone will sink back in, but won't sink into the defect because the plates will hold it.
Very good point. I think, yeah, very good point.
Second operation.
You've then kind of done a decompression, but you won't need the cranioplasty. I suppose it depends how bad the swelling is, isn't it?
Oh yeah. It's just for the trainees to know. But it's not too swollen, if that's an Irish way of putting it.
No, it's a nice way of avoiding another operation. And as we know, and we've talked about cranioplasties before, it's not an operation without complications. So that's a very good point, Michael. Thank you very much. And Donncha, I don't think it was mentioned, but once the decompression was done, an ICP monitor was put in, wasn't it?
Yes.
Yeah.
Yeah, I think he had high ICP during that unstable period, which justified why we didn't continue with another operation, if you know what I mean. Yeah. So he'd high ICP for that initial 24 hours, but it kind of settled at high normal values, 18, 19, 20 then. But of course, he was on in neuro ICU on the standard neurocritical care treatment in terms of noradrenaline and all that, and head up. But had full, beg your pardon, had full spinal precautions with the hard collar, and then had the cervical fixation the next day. But again, it highlights. I mean, this man, you have to see him. He's just made a complete, fantastic recovery. It's for a man who's coming down the N4 from the west of Ireland with a fixed pupil, who is now absolutely fine, and he's having his outpatient physiotherapy and that. So. Yeah.
Donncha, one question they've posted, someone's posted, is why was the CT scan repeated pre-operatively? I suppose another way of asking it is, are there situations where you would go in without repeating the scan? Had the pupil come down with monitor, things like that?
I think the touchdown CT in Galway showed a relatively small extradural, so we transferred him on the basis of that. But then this event happened in the ambulance, whereby he got a fixed dilated pupil. So there are 5 or 6 different scenarios which could have evolved from that. He could have got a contralateral hemorrhage. He could have had a brain contusion which blossomed. He could have, multiple compartmental. There's 5 or 6 different things. So we had to know what was the cause of the extradural, what was the cause of the clinical deterioration.
Yeah, I agree. I think if time allows, you're much better off being able to get a CT. And in Beaumont, people who work there know where the CT scanner is, right behind the neurosurgical theatre. So
a spiral CT in Beaumont takes literally 5 seconds to do.
Yeah, literally on the way into theatre, you can get your repeat CT scan. But obviously, if, for example, there is a situation, there are very, very rare situations I can think of where you don't have time to do the CT scan en route to theatre. And usually, if you don't have those few minutes, it's the cause of the problem. It's probably unsurvivable.
I think, James and Una did excellent work, in the background with regard to all these papers. But I think that's a very good take-home point. This 90 mils or 100 mils that James mentioned of the volume of the extradural. So it's something to bear in mind. I know it's controversial, as James said, but if an extradural hematoma is more than 100 mils, as Michael was saying, as MGJ was saying from Cork there, it might be worthwhile either doing what Michael does there or taking the bone off completely,
Very good.
The other thing I'd like to say is that, we're all under pressure in the health service with regard to various things, and sometimes cranioplasty doesn't get done for a while. But I'm a huge believer in putting the bone back early. You know, the American concept of the syndrome of the trephined, whereby, you know, there can be very negative effects based on PET scanning of the brain that's, you know, not covered by bone, you know. And so, you know, like leaving the bone off for 3 or 4 months can have a very inhibitory effect in terms of the patient's brain rehabilitation. And the Americans refer to that as the syndrome of the trephined. In fact, it can promote epilepsy, it can promote you know, hydrocephalus, it can promote a whole load of different deteriorating situations. So it's very nice to put the bone back, you know, 3.5 weeks later, and it allows the patient to move on to rehabilitation. But just anecdotally, I've just noticed over the last few years that if you do that, the patients get better quicker, you know.
I think that's almost a topic we need to cover on one of the other webinars, and maybe have some of our rehab doctors involved as well, colleagues.
It's worth the audience looking that term up, the syndrome of the trephined. It's an American term, you know, whereby somebody has part of their, you know, cranium removed for either post-trauma, tumor, whatever. Infection, of course, is the big one. Whereby it has to be removed and left out for a number of months. But during that period of time, based on PET scans and based on other imaging modalities, there are negative effects in that area of the brain which is exposed, you know, which isn't covered by bone.
Yeah, no, that's exactly why I thought it's a very good topic. The flip side to it is the infection rates, and there's in terms of timing. So it's a good one actually for us to review at one of the other webinars as well. That's great, Donica. Thanks very much to Professor O'Brien, Una and James for a really fantastic presentation, and for the comments by others as well. So we'll move on to the next case, which is actually very similar. I wasn't aware that your case was an extradural, so I had a case as well, and Stavros Kostas, one of our registrars, are going to present it. It'll just consolidate what we've been talking about, and it's a good kind of back-to-back presentation. So Stavros, if you want to kick off.
Thank you, Prof. Thank you, Prof, and thank you for having me. Yeah, a case of a 17-year-old teenager who sustained a rugby head injury at 3 o'clock in the afternoon with an associated brief loss of consciousness, but was well afterwards, and subsequently developed headaches and vomiting whilst at home. His family took him to St. Vincent's Hospital Emergency Department at 2000, and initially at triage he was GCS 15 with no focal deficits, but at 2100 he dropped his GCS to 10. His pupils were equal at the time, and the emergency department team in St. Vincent's got him a scan, which is the video here playing on the right, which shows a large right temporal extradural hemorrhage with midline shift. So based on this scan, he was referred to us at 2216, and he was accepted for transfer immediately. And our theaters were notified of the case that the patient will need to come to theater. However, en route, the patient dropped his GCS to 3 with a fixed and dilated right pupil and bradycardic. So he was promptly intubated in St. Vincent's, ventilated, atropine administered, and mannitol. So he arrived to Beaumont at 2311, and he went straight to theater. No repeat scan. A large trauma flap craniotomy was performed. He was bleeding from a lacerated middle meningeal artery, which was coagulated, and the dura was laxed after the operation, and multiple hitch stitches were placed to the dura. Day 1 post-op scan, which is the video being played now, was satisfactory, and the sedation was weaned off, and he was obeying commands, and he was successfully extubated. He was seen by Allied Health during his in-hospital stay, and he was discharged home on day 7. So we'll talk again. I wasn't aware that there was the extradural hematoma case presented earlier, so I prepared a few slides as well on the on extradural hematomas. So the incidence of this is about 1% in all head trauma admissions. Males are it's more common in males than females, and is usually in young adults, as mentioned earlier. It's very rare to see it before the age of 2 and also after the age of 60 because the dura is so densely adhered to the bone. 85% of the cases are as a result of arterial bleeding from a middle meningeal artery injury. However, the remaining of those can be due to meningeal vein injury or dural sinus or the fractured skull edges. 70% of the extradurals are located over the pterion, with the rest in a descending order of frequency, frontal area, occipital, and posterior fossa. The classic textbook presentation is actually seen in less than 30% of the cases. As we mentioned earlier, there is a brief loss of consciousness, followed by a lucid interval for over a few hours, followed by drowsiness, contralateral hemiparesis, and ipsilateral unequal pupil. However, other presenting symptoms and signs could be ongoing headaches and vomiting, seizures. Bradycardia is a very late sign, and ipsilateral hemiparesis, usually due to a Carnohan's notch phenomenon. CT, as seen on the last two presentations, you will have a biconvex shape hemorrhage adjacent to the skull, respecting the sutures. And even with prompt diagnosis and treatment, the mortality rate is about 5 to 10%, resulting from ankle herniation and midbrain compression. Now, in terms of management, this can be either managed surgically or conservatively, but we can all agree that any patient with an acute extradural and a GCS less than 9 and unequal pupils, they should have an emergency surgical evacuation. All extradurals more than 30 cubic centimeters and regardless of GCS need to be evacuated. However, any extradural that follows the following parameters can be managed conservatively with serial scans and closed neurobes in a neurosurgical unit. And those parameters should be less than 30 cubic centimeters, thickness less than 15 millimeters, midline shift less than 5, GCS more than 8, and no focal neurological deficits. And the reason being, things can change. The extradural can become chronic, or there may be more associated swelling, and patient can deteriorate. And if the patient deteriorates or develops neurological deficits, they should be in a neurosurgical unit so that the extradural can be evacuated promptly. In terms of tips for successful outcome, it's all about timing and communication. All kudos to the emergency department team in St. Vincent's Hospital, because the patient was promptly diagnosed and managed in an effective manner that didn't delay transfer, and also communication with all the relevant parties, including the receiving hospital emergency department here in Beaumont, the theater staff, and anesthetics. So essentially, the patient, as soon as they arrived in the front entrance of the emergency department, was wheeled straight to theater for emergency surgery. Thank you.
That's a great presentation, Stavros, and it's actually quite good to have the two extradural cases, I think, back to back, because it kind of consolidates things that we've been talking about. Again, I'll just go through some of the comments and questions, and if anybody else has comments and questions, put them into the chat function. You did mention Kernohan's phenomenon just for the non-neurosurgical trainees. Do you want to explain that?
Yes. With brainstem compression, or with mass effect, You have contralateral hemiparesis from the extradural. However, when the brainstem is pushed against the tentorial edge on the contralateral side, then the motor tracts on that side get injured as well. So you will have the ipsilateral hemiparesis.
Yeah, very good. So it's a kind of an unusual situation where you have a hemiparesis on the same side as a hematoma, which can be a little bit confusing from a clinical point of view. So in the days of no CT scans, you might end up doing your craniotomy on the wrong side, which wouldn't happen nowadays. Just a couple of things people have raised, and I'll just go through them. I think some people kind of often ask, oh, should a neurosurgeon not go over to the other hospital and do these types of surgery? I think we did touch on this before. There have been publications in the past showing that actually outcomes are better if you rapidly get the patient to a neurosurgical center rather than a neurosurgeon going to other centers in an unfamiliar environment, somewhere where the nursing staff and the infrastructure is not set up for doing this sort of surgery. I think a lot of people from their first aid courses think that removing an extradural hematoma is just making a little hole, a burr hole, and it isn't. It's an actual full craniotomy. It's a major procedure. And where you do it needs to be properly kitted out, and the staff around you need to know what they're doing. If my other neurosurgical colleague, Donica, do you have a comment on that? Are you still there?
Yeah, absolutely. Can you hear me, Mohsen?
Yeah, we can.
Yeah. No, the patient needs to come to a neurosurgical center. You know, I mean, the very most one would do outside is the burr hole, but I mean, that just relieves a tiny amount of the extradural clot. I mean, if this boy was delayed in another hospital, he would, again, you know, without mincing my words, he would be dead, you know. They need to come like blue light Garda escort straight to the neurosurgical, be whipped straight to the operating theater. No messing around, no holdups, just get on with it and remove the hematoma. So, you know, that's the whole idea. Oh, let's do a burr hole. I mean, that's just that's wrong. It's not.
I think it's a misunderstanding of the fact that acute hematomas are quite thick and solid. Yeah. They need a full craniotomy, and I think people mix.
The other thing, of course, is that there's an active bleeding point there, and whilst a burr hole will take out, say, maybe 5 or 6 mils of it, you know, it won't address the bleeding point, and also the whole neurocritical care thing needs to wheel into action in terms of cerebral perfusion and things like what James Maxwell very eloquently spoke about there, you know. So, you know, it's straight to the neurosurgical center ASAP.
And actually, while you say that, I've just pulled up some of the data we have from an audit that we did in 2021, which shows that once the severe head injuries that come to Beaumont that need immediate surgery, the median time to surgery once they hit Beaumont is 37 minutes. All are performed within 2 hours of arrival, basically. So once, you know, if the patient hits the neurosurgical center, they're in theatre pretty much straight away. Mr. Wael Mohammed, you have your hand up from Cork University Hospital.
Thanks, Mohsen. Thanks, Donica. Very two interesting cases, and I want to just highlight the technical difficulty sometimes, especially in the first case of Donica, where you have concomitant cranial and spinal injury. People sometimes under-evaluate the difficulty, especially the technical position, tubing, all the rest of it. It's absolutely nightmare for surgeons to operate while you have an unstable spinal injury. People think it's just a matter of kind of spinal precaution, but that in reality is very difficult. And oftentimes, you know, 2 o'clock or 3 o'clock in the morning, people will ask you a very simple question: what does that mean? And the translation of it in reality can be very challenging. With regard to the just quick point with regard to the decompressive, I think it's a very good discussion, and it will enhance a good discussion about decompressive craniectomy for extradural. I know the traditional thinking and the traditional teaching was that, you know, subdurals and extradurals, even though they look the same on the scan, but the etiology and pathophysiology of them are different. And that's why Subdural, we entertained the idea of decompressive craniectomy and ICP because of the associated parenchymal injury and secondary brain injury and swelling, while extradural doesn't, because it's normally above the dura, and it doesn't really concomitant with the parenchymal injury. So we tend to think that putting the bone flap, and I think that's kind of the standard practice. I'm just going to do a quick core thing, given that Michael Sullivan is on the line. I'm just going to quote his paper actually from 1990 in the British Journal of Surgery about extradural hematoma in the Irish Republic. He analyzed 82 cases, and really the emphasis was on delay. Nothing really major change in the meantime. We still treat it the same way, but the mortality rate, obviously with extradural, if left untreated, a couple of hours is very high. So people shouldn't underestimate extradural hematoma at any cost. Thank you.
Yeah, I suppose as well, Mohsen, thanks, Wild. It's excellent comment. It just highlights the whole importance, if that is a word, of neurosurgery in trauma patients. With the greatest of respect to other specialties, and management of these other injuries are crucially important. But both of these patients had an hour before they were brain dead.
Yeah, and I think that's really important. There is a comment here. There are a couple of recent case reports of successful extradural hematoma evacuation by non-neurosurgeons in remote hospitals. Is there a threshold of distance or time where this becomes a viable proposition? Donica, do you want to comment on that?
No, just to reiterate what you said there, Mohsen, it's a question of the setup, I mean, and it's a question of managing it. And then my anxiety about that is that even if one had done or had as part of one's training some neurosurgery and is working in a general capacity in in a non-neurosurgical hospital, and I would be very anxious about hypovolemia and a greater than average blood loss in that case, and removing the whole volume of the extradural hematoma, and then doing other measures which may be necessary, and whilst forgive me for putting it this way, whilst well intentioned, it may actually cause more problems than good,
Yeah, I think in general, as I was saying, it is better to transfer the patient quickly to a neurosurgical center than the extradural hematoma being evacuated by non-neurosurgeons elsewhere. I think that most of the instances in Ireland are such that you can get the patient to us quick enough if the patient scanned quickly and brought over. I've certainly been in a situation before where a general surgeon evacuated an extradural hematoma very well, but treated it like a general surgical problem, like an abdominal problem, and then packed the cavity, which is the point that Donica was trying to make, in that you need to actually get the bleeding point. And if you just do a small opening and you can't see where the bleeding is coming from, and you pack it with gauze, you've actually now compressed the brain even more. So there was a study, as I was saying before, by Graham Teasdale, the person who devised the Glasgow Coma score many years ago, I think around Scotland, where surgeons, where this surgery was being done in non-neurosurgical centres, or the neurosurgeon was kind of driving over to the non-neurosurgical centre and doing it there. And as I said, they showed that the results were poor in general. So I think best to transfer the patient to a neurosurgical centre and act as quick as possible. The other comment here in the question is very interesting. Talks from a neurotrauma perspective across the country. Is there, broadly speaking, an immediately available neuroanesthetist? Again, my colleagues can comment on that, but basically in the neurosurgical centres, the answer is yes. So once the patient has come to us, then there is a neuroanesthetist and neurointensive care available, but in other centres, I'm not aware of neuroanesthesia or neuro ICU being available. Donica, do you want to comment?
Yeah, that's what we have in Beaumont and in Cork University Hospital. We've got a specialist neuro ICU, so it's not just a question of scooping the extradural hematoma out. Then we hand the care of these patients over to our colleagues in neuro ICU, who Professor Curley and his great team, who basically keep the blood pressure up and max the cerebral perfusion pressure, and attend to other issues, cardiac arrhythmias, spikes in ICP, tendency towards syndrome of inappropriate ADH secretion, all that issue, avoidance of secondary pneumonia, so on and so forth.
I suppose everything we're saying is really pointing out to the fact that a proper critical care retrieval system, as David Menzies has told me, is really important. We need a system that gets the patient to the right place quick enough, and then you have everybody needed there, and the neurocritical care and everything is available there. So what we are all saying is really the same thing, is that the patient needs to be transferred as safely as possible, as fast as possible, to a centre that has the neurosurgery and the neurocritical care and everything in there.
Absolutely.
One further question, and then I think we'd wrap it up after that. What is the value of inserting an ICP monitor after craniotomy or craniectomy? I can answer that, or Donica, do you want to take that? I think it's good for training.
It's part of the whole neuro ICU algorithm, and that basically it's a detection system whereby an ICP monitor will detect elevations in intracranial pressure. So normal intracranial pressure is 10 to 15 millimeters of mercury, and we get very worried if it's over 20 to 25. And of course, then studies have shown that cerebral perfusion pressure, which is a function of mean arterial pressure minus intracranial pressure, that's how it's calculated, that has to be more than 60, 65. So it's part of that treatment algorithm whereby you want to avoid spikes in pressure, but at the same time you want to use that figure to compute cerebral perfusion pressure. So there's no point having the patient with high ICP afterwards, which further impairs cerebral perfusion.
Yeah.
So of course, then it's put in then as a warning system in that the patient may have a normal ICP initially, but then it may spike due to a reaccumulation of the extradural hematoma, or they may get other events such as formation of brain infarction or contusions, and an elevation in ICP will detect that, which will prompt a repeat scan, which then will detect that.
Yeah, so in other words, just taking the initial clot doesn't mean all is good. Now these patients need further ICU care and ventilation, and you need to be alerted if there is reaccumulation of hematoma or sometimes brain swelling, and that needs medical ICU management of the ICP. Okay, that's fantastic. I think the presentations were excellent. Thank you very much, Donica, and thanks to Una, James and Stavros for doing the presentations. Thanks so much, Donica. You made a lot of contribution to the discussion as well, and a lot of learning points, and also to Professor Michael O'Sullivan and to Wael Mohammed for their comments from Cork University Hospital. And see you all again on the first Wednesday of December. Thanks very much, guys.
Thanks, Mohsen.
Bye now. Bye.
Thanks very much. Thank you. Bye-bye.